I'm Ben Neal, and I'm the director of the Perlmutter Cancer Center at NYU Langone Health. And I'd like to thank all of you for dialing in. And what we like to try to do today is tell you a little bit about what you need to know about cancer diagnosis and treatment during the COVID-19 epidemic. So if we can go to the first slide, I want to introduce my colleagues who will be helping me on this call. So that handsome guy immediately to my right is my partner in crime, Dr. Handsome, otherwise known as Abe Chichua, and he's the section chief for the medical oncology at the Perlmutter Cancer Center in Manhattan. And to his right, that's Michael Grossbard, and he's the section chief for hematology. And we also have two of our colleagues from NYU Winthrop, Eva Chalice, who's my counterpart, the director of the Cancer Center at Winthrop, and Jeff Snyder, who's the division director for hematology and oncology at NYU Winthrop. Okay, so we'll all be taking answering your questions today, and also, any questions that you want to type in on the chat if we get them. Okay, so let's just move on. We want to give you a little bit of an introduction first about an overview of what the Perlmutter Cancer Center is doing during the COVID epidemic, and also what you can do. And I guess maybe we'll go back one slide if you can. I forgot to mention. So if you have a question during the presentation, you can email it to cancerevents@nyulangone.org, or you can call that number. So I'll give you a second to write those down. And there's also a way to type into the chat bar, and we're going to be monitoring. The chat is to the immediate right-hand corner of your slide, and we're going to be monitoring the chat during the session, and also those other venues if you want to send in a question. Okay, so now let's move on. Okay, so we understand that this, whoops, that was extra fast. So we understand that the COVID crisis has been very stressful for everyone. And the reason we understand that is that it's certainly been stressful for all of us as well. So we appreciate how this is a difficult time for pretty much everyone, and for some people in particular. And we understand that cancer patients, or people who are concerned that they might have cancer, may be particularly fearful about getting the care they need. And at the same time, cancer doesn't stop just because we're in the middle of a global pandemic of COVID. And so it's really important that we communicate to you, and that we're available to communicate to you about how to make sure your cancer care, if you're a cancer patient or a cancer survivor, is being taken care of during this epidemic, and how we're making sure that's true. And also to tell you, if you're concerned about cancer, how you can access us and get any questions that you have answered, and if necessary, get diagnostic procedures during this during this crisis. So, and during this time, we'll talk to you about exactly how we're going about keeping our cancer centers safe. So the first thing is, we've instituted a very stringent screening at all of our sites. So Perlmutter Cancer Center has 3 hospitals, but also a number of sites throughout the network where we deliver cancer care, and all of them adhere to the same screening policy. So all of our patients are going to be asked a series of screening questions when they come into the cancer center, and all of our patients are masked, and our providers are masked and gloved when there's any contact necessary. And we also limit the number of patients entering our facilities. So unfortunately, during the COVID crisis, to protect other patients and also to protect our staff, we do not allow visitors to come with cancer patients. It's just too much of a risk. We've had several cases of where the patient was fine, but the visitor turned out to be incubating or having COVID-19. We've also, inside the cancer center, we've altered our daily practices. So for example, we keep the doors open so that we minimize contact of our staff with handles, and also of our patients. We also increase the frequency of cleaning and common services, and we have a very rigorous cleaning protocol every night that basically does a strict cleaning of every room to make sure that everything is thoroughly disinfected. We can go to the next slide. So this is just an example of the screening questions that you would be asked, or if you're one of our patients, you will have been asked. You'll come to the door, and every patient has their temperature taken, and they're also asked these questions. I'm not going to read through them, but you can see that they basically cover all of the major symptoms that have been associated with COVID-19. Those of you who are, paying rapt attention to this epidemic in the news realize that some of the symptoms that we originally, that we now know are associated with COVID-19 have developed during the epidemic. For example, loss of taste and smell has been recently recognized as a symptom of COVID-19. Some GI symptoms even have been noticed. So we ask all of those questions, and in particular, we're very interested in knowing if a patient or their family member has had contact with COVID patients. Next slide. So let me just tell you, on a 50,000-foot high level, what our view is about cancer treatment during the COVID epidemic. So the first thing, and I think this is obviously the most important thing, is that we continue to provide the same level of high quality care that we're known for as an NCI designated comprehensive cancer center. So there's only 50 comprehensive cancer centers in the United States, and we're one of them. And that means that we have to meet a standard above most places in the country, and we maintain those standards throughout this epidemic. All of our cancer center leadership and our physicians are constantly monitoring the latest peer-reviewed literature and national guidelines to ensure optimal treatment decisions for our patients, and also monitoring the active literature, and it's very active, having to do with COVID-19 guidelines. So we're paying attention to that literally on a daily basis. Also, we've made adjustments to our therapies to minimize or reduce patient visits to clinics. So for example, routine revisits while you're on therapy would probably now be done by telemedicine. By telemedicine, we'll be talking a little bit about that later, but we have the capacity to do visits on your computer, on your phone, and also through devices like iPads. So I told you about our screening process, and I mentioned a little bit about telemedicine, and we're happy to answer questions about that if you have them during the meeting. We can treat your cancer even if you're diagnosed with COVID-19. It will obviously modify your protocol, but we will treat you if that's urgently needed. Okay, so I notice people are asking questions. That's good. We'll come back to them as we go through all the questions, because a lot of these have actually already been asked, and we'll cover them. So let me tell you a little bit about telemedicine. So telemedicine can be done, with most devices that people have. You can have a visit with the physician. You can call in and discuss your symptoms with a nurse practitioner or with a physician, and they can also assess your risk and take appropriate steps, such as scheduling a biopsy, imaging, or other testing, and arrange follow-up. And as of this week, we will be announcing a new suspicion of cancer virtual clinic. And we know that, for example, a lot of patients are concerned that they might have a suspicious symptom for cancer, but they don't want to come into the cancer center because they're worried about contracting COVID-19 during travel. And so this clinic will allow you to speak to the nurse practitioner who will assess your symptoms and decide whether you need to be referred to a physician, to another healthcare professional, or whatever is indicated. And we don't have the actual URL ready for this. We were hoping to try and have it for today, but you can check back intermittently through this week on our website, and I've put that there if you want to write it down. Okay, next slide. Okay, so now what we're going to do is I'm going to call on my colleagues to address many of the questions that you've sent in the mail. So we'll get started. So what are the biggest challenges that you face now when speaking with patients about their diagnosis and treatment plan? And why don't you take that, Abe? Maybe you can say a little bit about that, and then maybe some of the other people want to jump in.
Okay, well, thank you, Ben, and thanks everybody for joining. just for a couple of minutes, let me tell you who I am. I am a medical oncologist who treats mainly lung cancer. I've been at NYU since 1985, so I came and I never left. It was kind of a love affair with this place, so I'm still here. And I think I see patients pretty much 4 days a week. So that's me, basically. So now the question that you posed about the biggest challenges I face speaking to patients about diagnosis and treatment plan, I wasn't sure really how to answer that and whether it's meant to be for now with the times of COVID or before COVID. So I'm going to take a shot at both. So before COVID came along, being a medical oncologist was not actually, in my mind, the easiest thing to do. And I think the things that when you meet a patient for the first time, you're meeting a patient in a very stressful time for them and for their family. And they're coming to you out of kind of nowhere and asking for your opinion, putting their lives in your hands, asking, so you have to try and gain, first of all, the trust of the person that you see, and you have to kind of try and understand how to discuss whether it's a purely clinical, this is what I'm going to do, 1, 2, 3, 4, or not. And I say that because, back in my early days when I wasn't as smart, I had a patient come up in the first visit and ask me, how long do I have to live, doc? And I gave him the answer just like that, and I could see the blood drain from his face. And a year later, when he was doing well, he said, at that moment, I really hated you. So I think it's not easy for us to be talking about prognosis from the first visit. Fortunately for us, now treatment is much better than what it used to be. We have lots of options for how to treat patients. And I think a lot of the time with the visit, it's a discussion of what the options are until you get to make a final decision plan. It's unusual that you make a final decision on your first visit because sometimes we want tests to come back, particularly in the field of lung cancer. So now you're going to take all that and you're going to say, well, what's happening now with COVID? So with COVID, you have to then discuss the risks and benefits of the patient being treated while there's a pandemic in the United States. And that has the implications are for travel back and forth for testing, for chemotherapy, what's the implication of COVID on that? And you have to then try and decide whether the risk benefit is justified to treat the patient now or whether you can wait a little bit until the curve goes down before you start treatment. So for me, these are some of the issues I struggle with, but I'm sure others on the panel have a much more erudite answer than I have.
So let me just throw that out to the other clinicians on the panel. Do you have any comments on particular challenges you've faced when speaking with patients during the COVID crisis? So maybe Michael or Jeff or Eva, anything to say there?
I would echo, this is Michael Grossbart, and as Abe introduced himself, I've been at NYU a shorter period of time, a little over 5 years. My expertise is in hematologic malignancies, so lymphoma, leukemia, and myeloma. I think one of there are several challenges that Abe pointed out that are obviously true throughout both times, pre and post COVID, but particularly with respect to COVID. I think some of the things that are really challenging to discuss with patients are how does their treatment play out in the COVID era? What does it mean to get chemotherapy or biological therapy or immunotherapy and potentially suppress somebody's immune system while there's a very potent virus circling around? How can we adjust the therapy and reduce those effects as much as we can for the patient? How will that impact on their disease outcome? We can modify lots of therapies and only make little changes or no change in what our expected outcome is. So a lot of the challenge now is providing reassurance, making patients feel comfortable and safe coming in. Patients recognize that while we'd like to be able to have them come in as much as possible for their own safety, we want to minimize the visits and minimize their contact with others. So all of those are relatively new ways that we have to approach patients.
So actually, do we want to hear something from maybe from a surgical perspective? So Eva, can you say something and tell us
Certainly.
about yourself?
Yes. This is Eva Chalice. I'm a gynecologic oncologist and deliver both surgical and care and chemotherapy. Because of the COVID epidemic, we have been on hold for anything but super urgent or emergent cases. What we tried to do, and I think this was very intelligent in a sense that all of the diagnosis management groups got together and really discussed internally what is appropriate to do in terms of treatment plans. And there are many situations where we know patients are going to receive chemotherapy and or radiation in addition to a surgery. And very often the order of how this is delivered can be switched. And so for the patients who, for example, have ovarian cancer and we know they're going to need chemotherapy, that we are starting with the chemotherapy and then planning their surgery after a couple of cycles. I think as the situation is resolving itself, and appears to be, the operating rooms will open up and we'll be able to do surgery. I think the patients need to know that we're very thoughtful about our approach to how we advise them in terms of treatment. I think many of my patients have asked who are on ongoing treatments whether they really need those treatments, should they defer, and so on. And we've again reviewed on a case-by-case basis where it's appropriate to continue and where it's appropriate to hold, because it's safer for the patient to hold. In some instances, it's absolutely imperative that the patients continue with treatment, and under those circumstances, we've done exactly as Dr. Neal has indicated, which is to carry it out in a safe manner.
Okay, so I think that Jeff, do you have anything to add, or should we have a lot of questions? So if you don't have anything, we should move on.
I think I can add a little bit. I mean, this is sort of a general question, so I think it can take longer than some of the others. So Abe had mentioned that he arrived at NYU in 1985. Well, I was at NYU in 1986. I did my upon graduating from medical school, I did my residency there. And I thought Abe was there for many years before that, but I guess he had just arrived 1 year before. But what I would say is that at that time in 1986, we were challenged with another virus that was also very scary, and we lived through that and we rose above it. And I think there are a lot of differences, and obviously I'm alluding to the HIV epidemic, which took over my training at that time, but also that somehow we will prevail, and I think the HIV experience is very much analogous in the sense that it was very, very scary times, and it was previously unknown times dealing with HIV at that time. The only thing I really want to say about that, much has already been said, but I want to say two additional things about our dealing with this pandemic. We're all dealing with new constraints on our activities that is generically referred to as social distancing. And we socially distance from other people because we love humanity and we want to protect everyone, and it's uncomfortable and it goes against our instincts to not embrace other people more closely, but we do it because we know it's the right thing to do. The same is actually true for how we're handling this pandemic medically, and I would say that everything that you're going to hear about is what I would take the license to label as medical distancing. So we are actually, just like we goes against our instincts to socially distance from other people, our whole habit in terms of taking care of patients is, to be at the bedside, to hold a patient's hand, to provide a rapport that is very different than what we're forced to do now. But we're taking a very different tact because we care about our patients and we know that this is the best way to protect them. And so these are the measures of medical distancing. And the final thing that I'll say, and it'll be the briefest, is that as we do all these things and we go through a very difficult process, there is a silver lining. Part of it is seeing that we are successful in getting on top of the virus, but part of it is also discovering that some of the things that went against our instincts may actually turn out to be, in part, better practices. And some of this we will take forward to better the way we take care of patients in the future.
I will say that one of the things that I think will make a major impact, or already is making a major impact, is telemedicine, which is very convenient for many people. So I just want to answer one question that did come in over the chat, and then we'll move on to this other question I can handle quickly, and then we'll start taking some more questions. So somebody asked about the screening. Why do we ask if about loss of taste? Because their chemotherapy has caused loss of taste anyway. Okay, so these are screening questions. I should have said more clearly what happens if you answer one of the questions yes. So you're not sent home if you answer a question yes. You're taken to a room in the back where a nurse practitioner will evaluate you much more carefully. And if, for example, you've lost your sense of taste because of chemotherapy, they'll discuss it with a physician, and that physician will make a decision about whether they think it's fine. And if they do, Dr. Chichua or Dr. Grossbard, who are the site directors at their particular locations, will sign off on that, or Dr. Schneider at his location. So it's just an extra tier of caution. A positive screen doesn't mean you don't get to come in. Okay, so there's this other question here I can handle about the resources for immune compromised patients for PPE when they are used to travel outdoors. So first of all, the most important two things that you can do when you're outside are social distancing, which means not getting within 6 feet of anyone else while you're outdoors, and also just generally limiting your time outdoors. I know everybody wants to go outside. I certainly want to go outside on these, now nice spring days after a lot of dreary rain and a cold winter. But limit your time outside, number one, and stay at least 6 feet away from everyone else and wear a mask. And you can make your own mask. We actually are trying to retain most masks, like professional masks for medical personnel, because as you probably have heard, there are shortages of PPE for the people who have to take care of COVID patients in the hospital. But social distancing and wearing a mask, and then frequent hand washing. And when you wash your hands, you got to wash them for like 20 seconds. They say that sing happy birthday twice. If you've heard Dr. Chichua sing happy birthday, you wouldn't want to hear that. So you can sing whatever you want. So in any event, that's what you should do outside and limit the time you're out. So let's move on to some other, yeah.
Ben, the only other thing I would add to that question is, while we can't provide resources for people, everybody who comes in, every patient who comes in for treatment is given a mask, and they certainly can take that mask home with them and use it as we do for a week or more.
Okay, let's move on. Got a lot of questions. So next slide. Okay, so there's a bunch of questions that are sort of related, so we'll try to handle them together. So the first one is, how do you evaluate the risk? According to an unpublished paper from NYU, cancer was not a risk factor to COVID-19. So again, I'm going to take that as well. So what this study did not, we used to, I'm a scientist, and what I always say to my students is the absence of proof is not the proof of absence. Okay, so this study did not identify cancer as a risk factor, but if you actually look in detail at the study, they didn't break down cancer patients by whether they're active cancer patients on therapy, whether they, for example, had a very uncomplicated breast lump removed 30 years ago. What this study was a medical record review by our our electronic health record system. And so if you are carrying a diagnosis of cancer, score as a cancer patient. There were only about 160 patients with cancer in the entire survey. Okay, so we don't really know. It's quite possible that those were largely patients who had like an uncomplicated colon cancer or an uncomplicated breast cancer many years ago, or even 10 years ago. So I think that in other countries, cancer has had a very strong risk. So we're not sure yet what the absolute risk of cancer is, but we think it's much better to be safe than sorry. Okay, so the rest of the questions have to do with treatment, so I'll read them and then toss them over to some of my colleagues. So what's the nature and level of risk associated with receiving chemo and radiation? And what percent higher risk are patients undergoing treatment? Those are sort of the same question. So Michael, why don't you take those questions, the first two, and then we'll talk a little bit about rapid testing. So want to say something about that?
Sure. We're still learning about what the risk of chemotherapy is and the risk of the various therapies we do. It's everyone's belief, based upon data from other countries and some now from the United States, knocking down your blood count so that your white blood is not a thing to do necessarily if you can during the time of COVID. To put an absolute risk on it is difficult. There appear to be some type of chemotherapy and biological therapy that place patients at higher risk rather than lower risk. And again, we're very cognizant of that and trying to adjust treatment programs to take that into account. Often we can adjust, reduce the dose of, or eliminate one of the drugs for a brief period of time without having a significant impact on outcome. You want me to handle the second question also, Ben? The percent higher risk?
Sort of the same answer. I mean, we don't really know exactly what the risk
is. To reduce risk before coming in, obviously you want to answer a set of questions. For all of our patients who are getting chemotherapy or infusional therapy, we're actually seeing them via a televisit or video visit the day before in order to make sure that patient doesn't have any symptoms that would put them or others at higher risk when they do arrive at the office for the infusion.
So let me just say a little bit about rapid testing. So we are going to start testing all the patients, the chemotherapy, the active treatment patients who we think are at the highest risk within the next 2 weeks. So you know, the real problem with testing is that there's a limitation in the amount of testing that is available. Despite what you may have heard in the news, okay, all institutions in the New York area have limited testing capacity. This limited testing capacity is actually not because there aren't enough machines or there aren't enough skilled people to run the machines, but it's due to a combination of a lack of, kits that are necessary for running the test, a lack of, believe it or not, swabs for doing the nasal testing, and also in some places, depending on the time, a lack of personal protective equipment for the nurses or staff that need to obtain the swab for the test. So no one in the area can possibly test every patient. And also the rapid test, rapid is a relative thing. The fastest tests take about 45 minutes to get your answer back. So what we are doing is we are, beginning to start testing patients who we think are at the highest risk, which are patients on immunotherapy and patients with hematological malignancies, blood malignancies. They seem to have a very high risk in the early days of this epidemic. We're going to test them before they come in, and then they can come in and get their treatment. So there's also a question about what can you do to protect your immune system, and there's a question on the chat.
Sorry,
also
Ben, while you're on testing, I apologize. Can you also talk about the antibody test? Because I think that's what a lot of people are referring to as rapid testing.
Okay, so let me just give you a little bit of an overview about testing in general. So there's basically two different types of tests that one can do for COVID-19. One is what we call a PCR test, and that's the one that's the nasal swab. And what the PCR test does is it detects the RNA in the virus. So this virus is what we call an RNA virus. It has RNA for its genome. And you can do a test where you amplify the RNA from a nasal swab to see if the virus is there. So this is a test, a PCR test, or the one that's done with the nasal swab, tells you whether you are carrying viral RNA in your nose or in your nasopharynx. And that suggests that you may be actively infected, and therefore potentially contagious. The other kind of test that you may have heard about, because for example, Governor Cuomo says we're going to be doing widespread antibody testing. The antibody tests, there's two different types of antibody tests. One that tests for an antibody that's called IgM, and another that tests for an antibody that's called IgG. The IgM antibody begins to be made within 3 to 7 days after you're infected. Okay, so, and then the IgG antibody is made, 15 to 21 days later. So these are tests that tell you usually that your body is starting to mount an immune response to the virus. So if you're IgM positive, you might still have infectious virus, probably not, but you might. And if you're IgG positive, that indicates that that you were infected with COVID-19 at some point in time or not. Now, we're not really sure about, we're not really sure about whether having IgG antibodies is protective. So it means that you've been exposed and you've mounted an immune response, but we're not absolutely sure that you've been protected, although we think that it's highly likely that patients who are IgG positive will be at least partially immune to reinfection. There's also been a question about pre-surgical testing. So we are testing all of our surgical patients before their surgery. So anybody who needs to come in for a cancer procedure is tested by the PCR test. Okay, so there's a question here and online. Can you go back? Can you go back? The last question has to do, is there anything you can do to protect your immune system? And there's one question on the chat about diets. So we really don't have any good data at all about, diets or anything else that you can do to protect yourself against COVID-19. There's just no data at all. So there's nothing that anybody can recommend for that. How soon after the completion of chemo is the body back to normal? Maybe either Abe or Michael or Jeff, you want to take a shot at that?
Have Jeff deal with that one.
Okay, Jeff, I said you were going to get the hard questions. How soon after completion?
Yeah, I'm good. So I think that for the audience, that there's an important distinction between, first of all, with the question about COVID risk, between getting the disease and having the disease and having a more difficult outcome. We are more concerned that the cancer population of patients may be at greater risk, not so much of catching it, because this is so contagious that anyone would catch it, but that they may be more vulnerable to it. And treatments that we have may put you at risk in two different ways. So chemotherapy is known to weaken your immune system, and for that reason could potentially make you more vulnerable to an infection that we are counting on your immune system to combat. The ways in which we can protect you from those kinds of risks are by sometimes being a little more free to give antibiotics at a particularly risky time after chemotherapy, and also by giving medicines that some of you may be familiar with that can pick up the immune system more quickly after chemotherapy is administered. Another thing that I think we may be talking about later on in the program is that there are treatments that don't weaken our immune system that are largely referred to as immunotherapies that actually stimulate the immune system, and yet they pose another kind of risk that we're concerned about because some of the damage that this virus does is by eliciting an exuberant immune response. And so we think that some of those stimulus drugs to the immune system can also potentially be a risk factor. So we have built very cautious guidelines about administering those kinds of treatment in the face of potential COVID illness.
Okay, so let's move on. We got a lot of questions. Probably going to have to start shortening our answers. It's my fault. Okay, wait, you're going too fast. Okay. Can cancer patients continue radiation, chemo, or immunotherapy if COVID positive but asymptomatic? So what are we doing about that? Abe, you want to talk about that? Chemo, radiation, immunotherapy. There's also a question on the chat about whether immunotherapy puts patients at more risk of cytokine storm, ARDS, or other bad COVID complications. So maybe you can just talk in general about what we're doing about chemotherapy, radiation therapy, and immunotherapy in the COVID.
Sure. So what we've chosen to do here is patients who are test positive, we don't begin treatment or continue treatment for a minimum of 14 days from the resolution of symptoms, okay? Now you could ask, where did this 14 days come from? I think it's a little bit arbitrary, but I think us and most other places have adopted this number to resume chemotherapy. Now, as far as Jeff mentioned, immune therapy can put patients at a different risk because one of the side effects of immune therapy is lung inflammation, pneumonitis. COVID can cause pneumonitis. And interestingly, several patients we've had come in with no symptoms have a scan that they have lung inflammation. So we're a little bit afraid that if giving immunotherapy on top of that, you will cause worse inflammation. So what we're trying to do now for people with immunotherapy treatment is get a CAT scan to make sure there's no inflammation. And if there is not, we can proceed with treatment. If there is, then we wait for that inflammation to get better. And then along the way, we measure what's called inflammatory markers in the blood that can predict when the inflammation is going to improve. Bottom line is there's no clear-cut answers, but this is what we've adopted, and we think it's a fairly safe practice.
And what would you do if a family member has COVID-19 and you're currently undergoing chemotherapy?
I mean, I think obviously that is an issue. You try and, of course, practice social distancing from your family member. You try and keep them as far away from you as possible. Wear a mask. If the patient has no symptoms, then I think you can proceed with treatment. You may elect to wait maybe at some time after exposure to the family member to make sure that the patient is not going to develop symptoms. That's another possibility. And we think about seven days or so before you can resume. I think it all depends a little bit on how critical it is that you get your chemotherapy at the right time, or whether you can delay it a little bit. If we have testing available, we would test probably such a patient before we resume treatment. But that's just general guidelines.
And I think that what you're answering, and I think what we've heard from our other experts so far, is that this is a really personalized, context-dependent decision, right? So that's why it's not gonna necessarily be a one-size-fits-all decision. We have some guidelines, but ultimately you're gonna have a close relationship with your physician or physician team, and they're gonna collectively make this decision with you. Okay, so there's also a follow-up question from something I said on the chat, so I'll just briefly deal with this, which is why limit time outside? So if you're walking in the middle of a forest and there's no one around, there's absolutely no reason to limit your time outside. But if you're walking like near where I live in Manhattan, and it's very difficult, even when it's empty outside, and it is pretty empty outside on 2nd Avenue now, to not, have somebody shoot out of the door and all of a sudden it's difficult to maintain social distance. So the only reason to limit your time outside is from the standpoint of social distancing and making sure that you keep as far away from other people that you don't live with as possible. Okay, so a question about impacting and receiving chemo. I think we've sort of generally discussed that question. Unique risks associated with checkpoint inhibitors. Again, we've sort of discussed that question. We're concerned about the possibility that checkpoint inhibitors might, be that you would be more likely to aggravate pneumonitis or inflammation of the lungs if you had checkpoint inhibitor therapy and you had COVID-19. So we're extra careful about that patient group. Same question for PARP inhibitors. So Eva, do you want to say anything about PARP inhibitors or
Sure. So we have quite a few patients on PARP inhibitors because they're quite effective in ovarian, fallopian tube, and peritoneal cancers, particularly in people who have deleterious mutation in BRCA1 or BRCA2 genes. And, these patients have there's a small amount of bone marrow suppression, so they're a little bit more increased risk of getting an infection. But overall, actually, that treatment is very well tolerated. So I would say that in comparison to checkpoint inhibitors, it's sort of a night and day. I don't think that the people who are on PARP inhibitors have to do anything special other than practice all the recommendations that we've made for everyone else, which is social distancing, wearing a mask outside, frequent hand washing.
Okay, so survivors at high risk of COVID-19. I think we've also discussed that.
Ben, can I answer the question about the double immune therapy?
Yeah, sorry, I skipped that. Yeah, that's really important. Sorry, yeah.
So that happens to be actually a patient of mine.
Really?
And yes, and if you're listening, you're the only appointment I have for tomorrow. So if I say no, you shouldn't have it, I can take the day off tomorrow, right?
So that means you definitely should come and have your therapy. Is that right?
Yeah, I think it's quite fine to do it. I mean, I think you've been on immunotherapy for a while. I don't think it's an issue. Obviously, you'll get screened at the door like everybody else, and then you'll get to talk to me, which is even a bigger plus. But I think it's quite all right for you to continue treatment. Now, interestingly, for this particular person, we changed his program a little bit, so he doesn't have to come every 2 weeks, but he's coming every every 3 or something. I'm going to change his program so he's not here as often to get his immuno.
So again, I think that's, we didn't mean to be necessarily talking about a particular patient, but I think that just illustrates how, every single physician at Perlmutter Cancer Center is really taking each patient very personally, evaluating each patient's situation very personally and often in consultation with other specialists to make sure that that they're going to get the optimal care, taking into account this risk-benefit balance between the cancer and the COVID risk. And again, I just want to emphasize that we think that's the advantage of comprehensive cancer center care, is that you get that sort of multidisciplinary and very careful personal attention for every patient. Okay, so I'm not sure that okay, let's go on. I'm not sure, can I just say a little bit about that last question? Can we go back? So survivors are at high risk for COVID-19. So again, we've discussed that a little bit. I mean, I think it depends what you actually had. I think if you had, an isolated breast cancer and the tumor was removed and you had a year of tamoxifen or something like that, you're probably not at increased risk. If you had a colon cancer and, a stage 1 colon cancer and it was removed, you're probably not at increased risk. We don't think that COVID-19 is going to increase your risk of a second or third cancer. There's no evidence to suggest that, and no reason from what we understand about the way that COVID-19, causes disease that would make you think that that would be true. So I at least want to put that concern aside.
Right, but Ben, the cancer itself may not, but other comorbidities do that we see in survivors. For example, obesity. What's that?
Yeah, we're actually going to talk about some of those, but yeah, go ahead.
So no, I mean, I was just going to point out that comorbid things that you see, like being overweight, having other medical problems, heart disease, may make you a little bit more susceptible. So I think we'll get to talk about that later.
Okay, good. Let's go. We're going to go on. Okay, we have a question for Dr. Grossbard. I have multiple myeloma. You want to talk about hydroxychloroquine and azithromycin?
Sure. I mean, so there are lots of data out now about hydroxychloroquine, still only very small trials that have been published. I think the most important thing we can say at this point is that no one is any longer recommending hydroxychloroquine together with azithromycin. Azithromycin, which is a common antibiotic that's given for pneumonia and respiratory infections, does not have any activity in test tube type settings in killing the virus. And in fact, when the two drugs, hydroxychloroquine and azithromycin, are combined, you end up seeing a higher risk of cardiac problems. In the study that was done at NYU, 11% of patients had a potential abnormality on the echocardiogram, on an electrocardiogram, an EKG, that could predispose those patients to getting a very serious and potentially fatal arrhythmia. So hydroxychloroquine, the jury is still out on that. It's certainly not a miraculous drug, despite what people may hear at 5:30 every afternoon. But azithromycin has no benefit, and there are studies looking at hydroxychloroquine.
Yeah, I want to say the first part a little bit differently. So if there were a dramatic effect of hydroxychloroquine, if that were in any way a miracle drug or even a remarkably effective drug, we would know that already from even the studies that have been done so far. So, clearly it is not, a major, drug for this disease. Okay, whether it has some minor effects, particularly early in infection, whether it might decrease the severity, that's still not clear. But I think what is very clear is that this is not a miracle drug for, for COVID-19. So there was also another question here.
Ben, I think the point to answer this question, though, most importantly, is don't take any medications without your doctor discussing it with you.
Absolutely, because a lot of times you're on other medications that can interact with hydroxychloroquine and azithromycin, and you don't want to take that combination anyway. So, okay, so there's another question here that came in on the chat that's very relevant for Dr. Grossbard. I have been diagnosed with non-Hodgkin's lymphoma stage 4 with a mass the size of a peach and have 4 treatments of rituximab immunotherapy scheduled, but I rescheduled the treatments due to concerns about traveling to the hospital via the MTA, et cetera. What are the risks?
Rituxan is an antibody that kills lymphoma cells, and it also kills normal lymphocytes called B lymphocytes. So Rituxan can contribute to some degree to suppressing the immune system. In a given case, you really have to weigh the risk of the treatment versus the risk of the disease. And it's hard to answer this based on the information I have for this case. We've certainly worked to sometimes adjust Rituxan treatments. I think if you can, if your doctor feels that you need it at this point for your disease, then I'm sure they're making a reasonable judgment to give it. The risk of traveling, you clearly want to minimize as much as you can. Subways, fortunately, are somewhat less crowded, although they are running less frequently. So I think you have to work with your doctor. Anybody on this call really needs to work with their physician, who clearly is going to be considering all of these factors about disease, about COVID, about your risk of infection, to make a rational decision as to what the best way is to treat your cancer.
Okay, so there's also there was a question on the chat that's related to the immunotherapy questions that were asked before. So you said immunotherapy is a stimulus question, but there is a risk. Please explain. So let me try and explain that. So one of the complications of immunotherapy is that you rev up, the immune system so much that you get lung damage, and that's called pneumonitis. There are other kinds of inflammatory conditions that can be caused by immunotherapy too, but there's particular concern for pneumonitis, or even occasionally heart inflammation. And COVID-19, part of the pathology is that the people who have really serious COVID-19 infections have pneumonitis, and there's a lot of inflammation associated with that. So the concern is that if you have a low-level COVID-19 infection, that the immunotherapy might exaggerate the normal inflammation in the lung and cause pneumonitis. So that's why it's a stimulatory treatment, but it revs up the immune system, and part of the damage that you get from COVID-19 infection is due to a revved up immune system. So it's a little complicated. You don't want to have, you could be more susceptible to COVID-19 if you don't have enough of an immune response at the beginning, or you might get a more serious infection with COVID-19 than you would if you don't have enough of an immune response. But if your immune response is hyperactive, that's bad too. So it's sort of like a little bit of a Goldilocks situation where you want to be not too much immune system and not too little immune system. And that's the balance that we're trying to set. Okay, let's move on. Okay, we have a lot of breast cancer questions here. So let's see. Oh, we stay on that one. Okay, so breast cancer survivors at higher risk. And then some specific questions. Maybe Abe and Jeff, maybe you can tag team these as the solid tumor people. Abe, you want to start with that?
Sure. The first question we answered, are breast cancer survivors at higher risk? I guess obviously there's a bit of timing involved. If you define survivorship from the very first diagnosis when you're getting chemotherapy and radiation therapy, that's different from survivorship at the end of treatment and maybe on hormonal therapy. So I'm going to take this as at the end of treatment, when you're done with your treatment, maybe taking hormonal therapy. So you have a history of breast cancer, but no active breast cancer. So I would say the risk from that is not increased. However, as we mentioned before, cancer treatment and lifestyle can predispose you to certain things like increased weight, heart disease, etc. And these can put you at an increased risk like a regular population that has these things. So that's my answer to that question. Jeff can take number 2.
Okay, Jeff, you're on.
Okay, sure. So I am on tamoxifen for HER2 positive breast cancer as a 5-year survival. What are the risks of taking the medicine if I ever become positive for the virus? So tamoxifen is a hormonal agent and would not be predicted to compromise the ability to deal with COVID illness in the same way as some of the other therapies. Now, we don't we don't have a huge experience, but that, predictably doesn't seem like something that would be any concern whatsoever. So I would not instruct somebody on tamoxifen to change that, even if they had COVID illness. The next one.
Sorry, let me modify that for a little bit. So I think we know that people who have severe COVID can have coagulopathies. Do you think that tamoxifen can make that worse? It can increase the risk of thromboembolism? I mean,
sure.
Obviously, if you're very sick, you're going to stop the tamoxifen, but what if you have mild illness?
Yeah, well, so, tamoxifen has such a long half-life. I don't know that stopping it would reverse that, but you make a good point there. So as I say, that we haven't necessarily thought through every single nuance. So tamoxifen, a relatively benign drug. I've often told patients that it's better studied than almost any other drug that we have in the cancer arena, and it's although it has some risks, it's probably safer than a baby aspirin a day. But nonetheless, it does have it does increase the risk of clotting, and we know that when patients are very ill with COVID, like ICU type illness, that clotting is an issue, and so it's a point well taken.
But again, I don't want to make this a COVID management about COVID disease itself, but actually that's one of the things that's been increasingly recognized as doctors have had experience with COVID, that this clotting risk is real. And so all of our COVID doctors have adjusted our treatment protocols to try to avoid serious complications from clotting disorders. So, okay, so this is actually an interesting question. What about Herceptin and COVID? Abe?
So I think that's again, there are many scenarios where you use Herceptin, either in the adjuvant setting or in the treatment setting. I think the decision for that is going to have to depend a little bit on your physician. However, what I want to say is Herceptin can be given either once a week, once every 2 weeks, once every 3 weeks. So if you need to be on the medication, on this infusion, then I would try and pick a schedule that kind of stretches you out, not coming once a week for it. Herceptin by itself doesn't affect your immune system as far as I know, but I think it's the travel back and forth and the exposure. Echocardiogram, again, it depends a little bit, right? I think that's an exposure issue. Unless your heart is borderline to start off with, you can probably delay for about a month. I think we're coming towards hopefully the curve is gonna start to come down soon, or does it come down soon, Ben? That will be able to do it with a short delay.
What about if you've had COVID? Is there a concern that maybe Herceptin would be a problem? Do you need to get it?
So we do know that some patients with COVID have acute cardiac toxicity. And so when you're giving a cardiotoxic drug, and Herceptin is to some extent, we should probably get a baseline echocardiogram and get a follow-up echocardiogram sooner than you would have, like you would get it in 6 weeks or so, than you would otherwise.
Okay, so Jeff, do you want to say something about this person with ER positive, HER2 negative stage 1 cancer?
So I think when we're talking about the different ways we adjust management of cancer in the context of concerns over COVID, one of the major issues is, what are we achieving with our therapy, and how safe is it to delay that therapy? So this question is asked, and these questions are all very high level. So appreciate that. But this question asks about somebody who is concerned about their risk of having a delay in their surgery while they are on anastrozole. And anastrozole has been well demonstrated in studies that precede COVID illness, that it can be given to delay the timing of surgery. So I would think that this is one of the situations where we're doing something where there's actually very good evidence that you can use anastrozole to protect patients and delay their surgery until a time when the hospitals and the environment is more amenable to having the surgeries performed. That I think covers that question. And then the last one,
Jeff, before you go on, I think one of the questions here was that the person has elevated LFTs, osteopenia. Is it safe to just wait? And, you know, I think in terms of osteopenia, generally, if you're on medications that's hormonal, you don't get decreased bone or increased bone resorption for somewhere between 3 to 6 months from the time starting to take the medication. So I personally would say don't have those concerns. And I would say also trust that your doctor has reviewed all of this information and has considered the pros and cons of starting the treatment.
We already talked about the last question, so I think we're going to move on. We're going to stay on a little longer since there's a lot of questions. So if anybody has any pressing questions and they need to leave, you can send some of the chat and we'll try to get, I'm monitoring the chat. So if you can do that or call it in, we're monitoring that. So the next set of questions. Next slide, please. Okay, so this has to do with surgery timing. So we'll let Dr. Chalice take these. So there's a question about a colonoscopy. Do you want to comment about that? And then this small liver tumor.
Yeah, so I think most polyps that are discovered at colonoscopy are benign, but they may be a marker of increased risk of colon cancer, and that is why instead of a 10-year follow-up, the doctor suggested a 3-year follow-up. I would not be concerned. I would just wait until you can have the colonoscopy performed safely. And I think your gastroenterologist is a smart person for shutting down because the risk is significant to actually their staff from those procedures. I need to have a small tumor removed from my liver. My surgery has been postponed until midday at the soonest. Before surgery, can I get surgical release letters from a few specialists? Is it safe to go to so many places before surgery? I would suggest that you contact those physicians' offices and see if you can do some of this virtually. But in general, if you protect yourself appropriately, it should be safe for you to go where you need to go.
So that's an example.
Dr. Neal had said.
So that's an example where we're doing a lot of telemedicine consults for stuff like that. So I don't know where you're getting your care or what the specific issues are, and that of course matters. But these are the kind of things where if you can limit the need to actually go from place to place, that's a good idea. I just want to mention about the colonoscopy. So again, you know, that 3-month, 4-month delay is not going to matter. Don't forget about your colonoscopy. Make sure you get it once the number of cases has gone down and and most of these procedures are restarted. That's important too. But the virus, so that it is true that viral RNA, and again, this is coming back to how the virus, viral RNA has been detected in stool of people, for example, who have, GI symptoms, abdominal symptoms from COVID, but there's no evidence. No one has been able to culture the virus out of the stool. So when you have something like RNA, the test that we use, this PCR test, it's very sensitive. And so, for example, there can be no viable virus there, but you can still detect remnants of the viral RNA. And that, for example, you might have read in the popular press about people continuing to test positive for COVID. So the best data right now is that people have tested positive up to past 8 days or even out to 21 days in some cases, but no one has been successful at actually culturing live virus out of anybody 8 days or more after they've had the virus. At least I haven't seen any reports of that. So that means there may be RNA there, but RNA without living virus is not a risk. It's just a marker in a way that you had the virus there at one point. But if you don't have virus that's living, then you're not at risk of transmitting it to someone else, and you're almost certainly not at risk of reactivating it yourself. Okay, next slide.
Ben, before you move on, so do you think a virtual colonoscopy would be a substitute for a real colonoscopy?
That's a good question. I don't know. What do you think? You're an expert.
In virtual colonoscopy, they do put air in the colon, and it has to be expelled, which theoretically would be aerosolized.
Right. So it may not be.
Yeah. Okay, let's move on. We have some other questions about surgery. So, Eva, you want to keep doing these?
Sure. I'm undergoing through chemotherapy after lumpectomy for stage 1, found to have, I think that's BRCA2 mutation. My doctor recommends ovarian removal surgery and also double mastectomy and reconstruction. However, COVID-19 is pandemic. My last chemotherapy is scheduled next week. How and when do I proceed? So typically, surgeon will not operate on you for about a month after surgery. I think one of the questions was how long after I finish chemotherapy am I back to normal? And basically, your blood counts typically return back to normal, sort of a new normal, at about a month. So most surgeons would not operate for a month. Removal of ovaries is considered an elective operation in patients who have BRCA2 mutations. So depending on your age, the doctor might want to do it relatively quickly, or they may want to wait a little bit longer. Sometimes those procedures are done at the same time, where typically what I have done is there have been times when patients had to have breast reconstruction performed, and at that time we did laparoscopic removal of tubes and ovaries. So those are all things that I would strongly suggest you talk to your surgeons. I'm having surgery in early May, which is postponed. I never thought I'd say. I'm looking forward to the surgery. That's actually a good way to be, by the way, before undergoing surgery. But since I plan to be implemented post-biopsy, my question is, are there any special preparations pre-op and post-op? There are, and this is very specific for the type of surgery that you're having. So I would, again, discuss it with your surgeon's office and their staff, because they must have specific guidelines of what you should do before surgery and after.
And in particular, in our institution, you will get tested for COVID-19. So that will be a personal thing. So, and here's another, right up your professional alley, so you can take the uterine
yes.
Yeah.
My sister was diagnosed with class 1, stage 1 uterine endometriosis. Her surgery for 3/26/20 was canceled due to pandemic. She was put on progesterone and still bleeding. How long can she go without surgery? Honestly, that kind of surgery is, especially for stage 1 endometriosis, is considered elective. Stage 1 endometriosis is the earliest form. If she's not having acute pain, I would suggest deferring until things settle and you can come to the hospital safely. I would say to you that holding off is definitely worthwhile, and progesterone is actually considered effective treatment for endometriosis.
Okay, let's move on. We have a couple of PSA. So this is a quick one. How can the PSA be checked during this pandemic? Abe, you want to take that one? Abe, are you there?
Wait, sorry, yes. Somebody muted me. I guess it must have been Dr. Grossbard.
That could be. You didn't like your last. You might not have liked your last answer. I don't know.
I mentioned virtual colonoscopy. Boom! I go out.
Gone.
Now that was probably the gastroenterologist cutting you.
Yeah, probably. So I guess the PSA is checked in exactly the same way. It's a blood test. Now the question you're asking, is it worth going to see your doctor and get the blood test taken? And that's a more difficult one, or is it worth going to a crowded lab and getting it done? So that will depend a little bit.
How about skipping, or even skipping a month? That's the kind of thing where you might be able to get away with skipping a month or two, right?
What I was about to say, yes. That depends on your PSA history, okay? If it's used, if it's just routine monitoring and you can wait a month, I would do that. If it's important to do it, then I would get it done. And I think that, sending the other portion of this is people have asked about sending a lab tech at home to draw blood, and I think that's probably also unsafe to do. So if you can wait. If you can't, then you have to go to the lab.
Okay, so this is actually not a COVID question, but do you want to take a shot at that, either you or Jeff?
So Provenge is a treatment that's approved for use in treating prostate cancer. It's actually approved for use in people who are hormonally resistant, who have minimal or no symptoms related to the cancer. It's a very select subgroup. It is actually a very interesting form of immune therapy. It depends on activating a cell called the antigen-presenting cell So you have to go to the blood center. You have to get your blood cells siphoned off. These antigen-presenting cells are separated and activated and then given back to the patient. So that is what Provenge actually is. It's fairly well tolerated except for some fevers. Let's see, you qualify if you have what I just said, prostate cancer, doesn't respond to hormonal therapy, minimum or no symptoms from the cancer. So the efficacy is, it does actually have some survival advantage. I'm not a prostate doctor, so I'm not exactly sure what the numbers are, but it's not a cure for cancer, but I think it's a very worthwhile approach.
So we have a question on the chat about is it safe to stop immunotherapy during COVID? So that's Abe, do you want to take that? That's really up your alley also.
I'm sorry, say again the question.
Is it safe to stop immunotherapy for a cycle or two during immunotherapy?
Right. So again, it depends on where you are with the disease, right? So if you've been in remission for a long time and getting immunotherapy for, we normally try and give it for at least 2 years. But if you are doing well with it, then yes, you can stop the treatment and watch, either stop it altogether or skip a couple of cycles. If the effectiveness of the treatment is borderline and your oncologist says you should continue it, then I think I would stay with it, okay? But generally speaking, skipping one cycle of immunotherapy is not the worst thing you could do.
Right. So again, and this just really emphasizes the fact that there's not a one-size-fits-all answer for most of these things, and it's really important to have a close relationship, with your doctor. There's also a quick question on the chat about taking palbociclib for Ibrance or for metastatic breast cancer. Does somebody Jeff, do you want to take a shot at that? Is that a risk?
I'm not aware of it being, particular risk. I mean, it can lower blood counts, and in that sense, we have to watch closely for, the same kind of concerns that we would have with chemotherapy. But I'm not sure the question is particularly in relation to COVID. I wouldn't be aware of other risks.
Okay. Do we have any other questions here? We're getting close to the end. Next slide. Is that it? Are there any other questions on the slides? Okay, so there are a couple of, let's just do a couple of extra questions on the chat which came up. Any thoughts on IV? This sounds more like a COVID question, but I will ask it just to see if any of our panelists have any thoughts. Any thoughts on IVIG treatment during COVID? Now, maybe Jeff, do you want to? This is sort of something you've been looking into. Do you want to discuss the difference between what this person is calling IVIG and they may be confusing this with convalescent serum? Do you want to talk about that?
Yeah, as I said, it's a very sophisticated audience. So there actually is. What Dr. Neal is referring to is that there's something called convalescent plasma, which is plasma that is enriched with antibodies against COVID, and that comes from people who have recovered from COVID, and in the aftermath, when they're convalescing, hence the name convalescent, we collect their plasma and it's enriched with antibodies. But there's also some data for just giving what's called gamma globulin, which is just antibodies that are not specifically against COVID, and there have been some reports of effectiveness of that. So either there's a little bit of confusion between the two, or it's a highly sophisticated question. But I think what's more so in the public eye and in the mainstream, even of COVID doctors, is this strategy of collecting the blood and hence the antibodies from patients that are recovering after they've been ill with COVID. So this is an exciting opportunity. There are a number of other diseases where this is done effectively. So, for instance, if anybody has ever been afraid of, the potential of developing rabies after being bitten by a rabid animal, the way we treat that is basically with a serum that's enriched with antibodies against the potential infection. So it's also used for measles, and it's been used in other viral epidemics. And there is a good amount of evidence that there is some efficacy. It's very early in terms of the information we have in terms of how effective this is for COVID, but yet we are piloting a program at NYU. And one of the things that I would say is that we're trying to be very obviously, we want to help patients first and foremost, but we also want to contribute to the knowledge base so that we'll know in the future as to whether or not these therapies are worth pursuing. And so we're actually doing a very sophisticated trial, which is a randomized trial between this kind of collected plasma from recovering patients and a control group that doesn't get it, so that we'll know if it truly helps or not.
So there's also a
Ben, can I try answering that question in a slightly different way, because I interpreted the question differently.
yeah, I think this person is actually on IVIG, by the way.
Yeah, and I think someone's asking what IVIG is given, immunoglobulin is given for people who have low immunoglobulin levels to prevent infections.
Right.
The question there is fashion during the pandemic.
Right. So actually, if you're taking IVIG, you're probably taking it because you have too low antibodies, and so it's not like it's going to rev up your immune system, which I think was the question.
It's a separate issue.
Right. And there was also a question about whether aromatase inhibitors, well, anastrol, which is an aromatase, does that compromise the immune system? So the person who's on IVIG, yes, that's normalizing your immunoglobulin. So that just makes you like the rest of everybody else. So yes, you should continue to take those. There's
like I said, there's also evidence that giving gamma globulin to people that have normal immunoglobulin levels may be helpful. So there's a few series of reports. So it's a win-win. Obviously, if you're already deficient, but even if you're taking for other reasons.
There's another really interesting question. So in anastrol, there's no evidence that that's going to immunosuppress you, as far as I'm aware. Is there any evidence, you guys?
Nope.
Okay.
No.
Here's an interesting question. So how are you, I'm not sure I understand the question exactly, so let me read it and make sure I'm parsing it right. How are you identifying asymptomatic but highest risk of COVID complications patient populations? And again, we consider cancer patients as being potentially high risk of COVID complication patients. We also know now that there are certain groups that are high risk. So over 70 is the highest risk. Being male is a risk. Obesity is the highest risk besides being over 70. Chronic heart disease and diabetes are also risks. So we know that all of those things together are potential risks, okay? And would these folks get retested on a specific schedule? So did you want to talk about that, Abe? Maybe, what are we doing about testing going forward with or Michael, maybe you want to talk about heme malignancies patients.
Michael, go ahead.
You still there, Michael? Oh, there he goes.
Apologize. Clearly, there are classes of patients like hematologic malignancies patients, like immunotherapy patients, that we feel are at higher risk, even if asymptomatic. And as many people know, 20%, 25%, even a higher percentage of patients may be COVID positive but asymptomatic. So we hopefully within the next 10 days to 2 weeks, we'll start testing all of our patients who are receiving therapy, who have hematologic malignancies and are on immunotherapy. And depending upon test availability, we can expand that later on. For now, we're just going to test at the initiation of therapy. Again, depending on availability of tests, it would be nice to test more frequently if one could. On the other hand, it's our hope that in 3 weeks, 6 weeks, 7 weeks, 8 weeks, we'll be seeing a lower incidence of COVID in the community for the time being, and that may also help us get away without testing.
Yeah, that'll give us two things. So first of all, the lower the incidence in the community, the more tests we'll have available to test our high-risk patients, probably. And the other thing is, the less likely that people will get infected. So both of those things are good. Here's a very interesting question that if blood tests are needed from more than one NYU oncologist, how can they be best coordinated? That's something we ought to be able to help with. So Abe, you're the clinical cancer director. How can we do that?
The question is if blood tests are needed from
NYU oncologist.
From more than one?
Yes. I guess
Okay,
like a
so, I mean, I guess the question is, why are we seeing more than one oncologist? Maybe one of them is a hematologist, maybe one of them is a medical oncologist. Luckily, Ben, we're all on the same system, Epic, and where we can see each other's orders. So I think that is self-coordinating, unless you're going to an outside laboratory, in which case one of those guys will have to write one prescription.
And again, we're also we're coordinated with our Winthrop colleagues, as you can tell from this phone call. So you can even arrange your. In fact, we're actually sending some of our Manhattan patients are getting their blood tests in close to their house at one of our other sites. Isn't that right?
That's correct.
Okay, so here's probably going to be our last question, I think, and this is a question that I think you must get a lot, and I won't answer it because I'm biased. So, can supplements be harmful? I have been taking homemade elderberry and turmeric and ginger. The general issue of supplements in cancer care, without your oncologist knowing about them, or even with the oncologist knowing about them, and then in particular in the COVID epidemic. Who wants to take a shot at that?
I mean, I can take a shot, which would be different from any other shot around this phone call. So I think that just the majority of patients that we know are taking supplements, okay? So I think we have to, as medical oncologists, rather than saying, no, you're not allowed to do it, I think we have to have a little bit of a better understanding what they are taking. So if somebody's taking turmeric and ginger and elderberry juice, I think that's actually quite fine. So, however, I do request that all my patients tell me what they're taking, and there are certain things that perhaps we say don't do, like vitamin A, for example. There's a study that said, and beta carotene, that says that outcomes may be worse. At least it was not a good study, but it was a study. With radiation therapy, things that generate free radicals are probably not a good idea. So I generally like to know what the patient is taking, and then I can try and render an opinion as opposed to saying a blank no. In the COVID era, obviously, if you're taking things like hydroxychloroquine, there might be lots of drug interactions, and that's a little bit of a different thing. And I don't think I know enough to give advice of that. I think safer, if you have COVID, not to take any extra meds while you're doing that until you get better. Now, I know most other oncologists will say what I just said now is heresy. But I said it, and so that's it.
So this is Eva. I actually kind of fall in between, in a sense that I generally discourage patients from taking any supplements while they're receiving active chemotherapy, mainly because some of the agents, particularly the antioxidants, can actually interfere with effectiveness of some of the agents that we administer. But I agree with you 100% that we have to review. The patients have to be honest about what they're taking. I would strongly suggest for any patient looking for any medication as far as cancer is concerned or anything else that's alternative medicine to refer to NIH. They have a whole area of complementary medicine, and at least can tell you, I mean, a number of years ago, black cohosh was a very popular thing, and women were thinking that this was going to help them with hot flushes, and several people had significant liver toxicities and really serious problems. So, whenever somebody says something to me that it's a natural product, my answer is arsenic is a natural product, and you really have to be very careful about what you're taking, what you're putting into your body.
See, I always say aflatoxin is a natural product, but that's just a different. Anyway, okay, there is one more question that I think we should ask Dr. Grossbard, because I think the person who wrote this might be being confused with another agent, but apparently a person said that they had bad COVID and they were given leucovorin and got much better. That doesn't sound right unless the patient was on a chemotherapy that had a leucovorin rescue. And then here's another one. A comment about leucovorin is not a question. Wanted to look to see if this would be a potential treatment. I was in an NYU hospital in mid-January, and I've been sitting next to a coworker who came back from Wuhan and told them that leucovorin. So can you explain what leucovorin is, Michael?
So leucovorin is a folic-like drug. So it's folic acid essentially, which is a part of the diet. It's an essential part of the diet, but I don't, and it's important in producing blood cells and important in a lot of other processes in the body. I don't actually see any mechanistic sense where it could be helpful or harmful for that matter, but particularly where it could be helpful with respect to COVID.
Yeah, I don't either. I'm just wondering whether this person was like getting, I don't know, some reason getting leucovorin rescue, and that might make it better. But I
So
don't
the
know.
only reason why we really give leucovorin is nowadays in the hospital is if you're taking a medicine called methotrexate, we give it in order to reverse the effects of methotrexate, which is a chemotherapy drug, or we give it in conjunction with another drug called 5-fluorouracil to enhance the activity of that drug. But outside of that, no one administers leucovorin in the hospital for any reason that I'm aware of.
Yeah, it was leucovorin rescue, so that might make sense, right? It says the person answered there was leucovorin rescue. So again, if your white counts are low, it might be better to raise them.
So exactly. So that's a separate issue, and it will enhance the
I
white
think
blood count, and it will enhance. Yeah.
right. That's the kind of exact complexity that can really confuse people because you might think that, well, this person got a lot better because they got leucovorin, but the reason they got better was because the leucovorin was rescuing the chemotherapy that they had before. So okay, so there's one last question, and then we'll wrap it up. So there was a question from somebody again on the chat about whether being on immunotherapy might prevent you from getting COVID because your immune system is revved up a bit. So again, I think that all of these things, that's a good question. I mean, we really don't know the answer whether if you're on what we do think is that patients who are on immunotherapy and then they get COVID might be at more risk of inflammation. Whether there's any lower chance of getting COVID in the first place because you're immunotherapy, I don't think there is, but we don't know. So does anybody else want to answer that question? I will say one other thing about the supplements. So antioxidants are a really good example of how things that everybody thinks are rational turn out to be irrational. So the emerging data in the cancer biology sphere is that antioxidants, if you have a cancer, are probably bad. They probably make the cancer grow faster. Okay. Antioxidants may, if you've been eating, like a mixture of antioxidants and things like that in terms of fruit and vegetables, that may prevent you from getting cancer. But if you already have cancer, antioxidants probably make it worse. So that's just an example of where you have to be careful and not just assume that things that sound logical turn out to be really logical. Okay, so
Matt,
yep.
So for the first part of that question, the immune therapies that I'm telling this to the audience, but the immune therapies that we use are designed to sort of reveal cancer to the immune system and prevent it from hiding from the immune system in a way that the virus also actually co-opts a similar mechanism. So it's not inconceivable that virally infected cells, which upregulate something called PD-L1, may be actually hiding from the immune system the same way cancer does. So we're very concerned about the possibility that the immune therapy drugs might rev up inflammation, and we've talked about that. But to the question that was posed by the person presenting it, it's not inconceivable that these therapies may actually prevent COVID by allowing the immune system to recognize it.
Right, but it's very complicated though, because again, the whole purpose, the reason why we have PD-1, PD-L, so the way that these drugs work is by blocking this checkpoint. The reason we have that checkpoint, the reason why we've evolved those checkpoints is to prevent chronic virus, is to prevent viral infections from getting out of control. So again, that's the reason why we're concerned that if you have it already, it'll get worse. Whether it will give you a better initial response and prevent you from getting bad COVID, we don't know. So it's just, we don't know. One last question that just came in. So my cancer center is recommending Neulasta for GCSF for all chemo patients, whether their white cells are low or not due to COVID-19. Michael, you're a hematologist. What do you think about that?
I don't think that's necessary. Fevers and infections, but unless you meet the guidelines otherwise, I'd be pretty unlikely to use it in this setting in order to keep the white blood count high in the COVID era.
So again, it's another one of these, getting the right level correct. If your white cells are too low, you might want to have it, but if your white cells are normal, no evidence that it would make it better. Is that a good summary?
Fair enough.
Okay, so I think we've pretty much gone through all the questions, both on the chat and on that were sent in advance. So I hope that we've been helpful and allayed some of people's concerns and try to give people advice about how to make it through the the rest of the COVID epidemic and make sure their cancer care is not compromised. I just want to reemphasize that we're going to have this new virtual cancer diagnosis, virtual cancer clinic online sometime this week. So please check our website at nyu.org/cancer if you're interested in that virtual cancer clinic. Any last words from any of our panelists? Okay, well, I want to thank everybody on the panel for taking all this time, and please do, if you have any other questions for us, you can continue to send them to the email address, and also, I guess we'll probably follow up to see if this was helpful to you and whether we should have more of these in the future. So thanks, everybody.